It's my office.
Oh, oh no. Now it's saying, sorry.
It's okay. It's fine.
Now it's saying my LinkedIn isn't added. So I
Oh,
am,
boo. Definitely want your LinkedIn on there.
yeah, that doesn't make sense. Okay, cool. I think I'm alive.
I see it. It's working.
All right, all right, all right, all right. What is going on, everyone? Welcome back to another episode of the Red Pill versus the Blue Pill. I am Dr. Delon Canterbury. I am the founder of the Deprescribing Accelerator, as well as GeriatRx, and I'm here today with one of my good friends and colleagues and confidants, Dr. Brittany Lamb. What is going on, Dr. Lamb? How are you?
Nothing. I'm just enjoying, well, not enjoying the weather today, trying to stay warm and dry, and happy to be here and happy for the new year and all the things we've got going on. So thanks for having me.
Man, I'm pleasure to have you on board, man. You know, we met just a couple years ago talking
Yeah.
about our passions for dementia, caregiver advocacy. So I'm so glad we can keep our momentum going, our friendship, and share a bit more on what we've learned, what we see on a day-to-day, really with over medications, right? That's one
Mhm.
of our pet peeves. So
Mhm.
go ahead and just give the audience a little rundown on your brief history of what you do currently
Yeah.
and what you're getting into lately.
Yeah, so for everyone who doesn't know me, I'm Brittany Lamb. I'm an ER doctor. I've been practicing now for as an attending for about 6 years, and I got pretty burnt out by our healthcare system. And as part of what I decided to do to treat my burnout was come online and educate and teach and start a business. So I run a small business that supports dementia families, the people in the families that are making medical decisions for the person living with dementia. So I really stick to helping people anticipate and learn and plan for the medical issues that will come up with dementia, and because the person is an aging human. So I think people are capable of learning what is to come and having a plan for how they're going to make decisions on behalf of that person. So I built a course, and it's out there in the world, and you can buy it and take it, and then you'll know what you need to know to have a plan. So it was a need that I still see every day in the ER. So, but yeah, that's why I'm here. And I love your mission, because I think a lot of the visits I see in the ER with people who are aging are because of medications in some way. You know, it may
Mm.
not be the entire reason that they're there, but it played a part. So,
Right.
so yeah, that's me.
I love it. I love it. I love it. And I mean, you're an ER physician. You've said, I'm tired of seeing these admission codes for polypharmacy and prescribing cascade. And you say, you know what? I want to advocate better. I want to do something different. I want to create my own program and really hit home where people have the most need, right? Navigating a tricky healthcare system,
Mhm.
knowing how to push back, and you have the inside scoop because you know how things work on the back end, right? You know the admin stuff, you know what they're trying to force people to do. So I'm curious, like just in this world of advocacy, what was something that really has resonated with you and how you've helped patients or how you help families really maneuver this complex landscape?
Yeah, I think a lot of it is language based. So it's communicating with the team and just knowing what words to say. So, not too long ago, I saw someone post on Facebook in one of the dementia support groups that they weren't allowed to come into the hospital because not because of COVID. I can't remember what the situation was, but they weren't letting visitors in. And this was, more recent. So COVID restrictions have loosened up, and I don't
Right.
know what the details were, but I said, this is what you say. And I typed out this response, like, call and talk to the patient advocate. And if you can't talk to them, then talk to the charge nurse on the floor. Tell them that you're concerned your person's going to become delirious and is going to require medication to chemically sedate them. And then they're going to be in the hospital longer and have more complications and need to
Right.
go to rehab, and, like this whole thing. So she basically read that to this person on the phone, and then she was allowed access into the hospital. So, and she commented back and told me like the same day. It was so great. So
What?
yeah, it's like, I never met this woman. This is the power with it. This is the power with us being willing to come online as professionals and help people. I mean, it literally took me 5 minutes or less to write that comment for her, And I think I even dictated it, like spoke it, and it typed it for me, and it's crazy, like all the good that you can do online. So I think that's one of the big things is what I like to do inside of my course is these are the questions you need to ask. This is the language. This is why we're doing what we're doing, and teaching people kind of, like you said, the behind the scenes type stuff. So yeah, that was one powerful thing that stuck with me recently.
That's super powerful. I mean, what would have happened if they'd not been seen, right? Like, what would have happened to that patient if you weren't there? So I think that's the piece in our professions that we tend to neglect, is how much we're at our core just advocating. We're just advocating. We're just educating and advocating and using a bit of our skill sets to help people get on to where they need to be. So I love that win. That's a great win. That's amazing.
Yeah. So that's one thing that's been going on recently. And then I've had, a lot of people reach out to me and say that 2022, because they found my blog, it kind of changed their year, which is so crazy. I've never talked to folks, and they're like, because of what you're writing on the internet, on your blog, which is 100% free, it allowed me to have a conversation with my family, to, think about our goals and what we're doing with our healthcare, maybe go and update advanced directives and kind of understanding that the practicalities of those things. So yeah, I mean, it's been really great coming online. And I think the power to help people advocate for themselves. I think that's also the thing, is that healthcare, there shouldn't be so many barriers to advocating for what's best for you. Yeah, there's a lot of education and understanding that you need to know to be informed and have a conversation, but I think people shouldn't be afraid to speak up and advocate for your family, advocate for yourself. If something doesn't make sense, just ask a question. And people are afraid to ask questions of us. And so I think just becoming more approachable. I think that part of being online is allowing people to see us like, you're a pharmacist, you're a professional, like you have all this expertise and knowledge, and you're a human being just like I am. So it's making things a little more approachable.
Yeah, approachable. Like you say, language matters, like knowing the codes that they will use to jump at whatever you need done. But like you said, we're in a digital age now. Like, healthcare can be done over Zoom. It can be done over a phone call. It could be done with a text. And we're seeing models where this is being done, and sometimes even billed for. But to your point, I'm able to help people across the world, across the country, with some general advice around what I just know about the meds, and hopefully incorporate some more of those deprescribing opportunities worldwide. And that's the whole point of this. So thank you for sharing some of that. So as we've had our discussion today titled, we're talking about why an ER physician and a deprescribing pharmacist are dementia's worst nightmare. And so for those who may not know, it's true. We are here to take on this broken healthcare system. We're here to deprescribe. We're here to stop polypharmacy, these prescribing cascades, and better educate clinicians so that they're a little more open to some of these suggestions, but also incorporate it sustainably into their standard of care. So if you don't know, I've actually done a number of discussions. In fact, I'm doing another one on Monday. It's a brain health symposium with the Alzheimer's Association and AARP. And we'll be talking about which medications to avoid prescription-wise or over-the-counter for patients who may have some cognitive impairment. And so, of course, I always talk about how much my grandmother has played a role in me creating this company. For those who may not know, she had some mild cognitive impairment, and having suffered from that, she was given an antipsychotic while she was in an assisted living facility. And she was given, I believe, Ziprasidone in this New York clinic. And we didn't know why her behavior was out of control. We didn't know why she was getting worse, sundowning. But it got bad enough to where my parents had to move her from New York down to Georgia, where I'm currently now in my parents' home. And she was here We had to actually child-proof the house and do all types of things to make sure she doesn't escape. And she definitely found ways to escape. But needless to say, we found out after struggling for months that it was just one prescription that caused all of it. So 4 months of help from my parents. I wasn't quite a pharmacist yet to advocate to the level that we do today, but it is why we are their worst nightmare. Because now we're going to take this on. We're going to hit the issue that we're seeing in real life, which are unfortunately more and more of these senior living facilities inappropriately diagnosing our patients with schizophrenia and bipolar disorder. So they don't have to report how many of their patients are being chemically sedated or basically using a pill to knock someone out. So they're just drooling to the left. And so it shouldn't be like that. But what are your thoughts? There was a recent article that CMS and the Associated Press highlighted about this newer crackdown or newer focused crackdown on stopping the use of antipsychotics that are being prescribed willy-nilly. I mean, there's been almost like I think a 20% spike in just the last couple of decades.
Yeah. I mean, I think maybe some of that spike is because there's more people who are aging, but it's so complicated with dementia because obviously we know there's a lot of turnover with staff. COVID caused a lot of havoc in a lot of these facilities. You have people who are inexperienced, who don't know how to handle people living with dementia. And we know that medications are not first line in dealing with behaviors, which are the symptoms of dementia. But there may also be there may be anxiety and depression and those things that are going on. But labeling someone as a newly diagnosed schizophrenic or bipolar disorder when they have, clearly have documented dementia and they're towards, they're aging, it's highly unlikely that someone would develop schizophrenia or bipolar disorder at that time of life. Like that doesn't happen, like we're talking in your 20s and your 30s. That's when we usually diagnose and start noticing the symptoms of schizophrenia. So that's very troubling, I haven't seen that as much in where I practice, around where I live and work. But there are lots of patients that are on antipsychotics. And I think that it's a complicated issue because, you want to keep people safe. You want to try to improve their quality of life. And it's an individualized decision and it should be a tool. It shouldn't be a go-to drug. It should be, we've tried other interventions and we think that this might be worth the risk. And the family also needs to be educated about the risks, the risk of antipsychotics. I mean, they have a black box warning on them. For people who have dementia, but when you look at the arsenal of meds that we have to treat, behaviors and symptoms of dementia, we just don't really have any. And everything that we have all works in the brain. So of course it can cause worse problems. So it's a very complicated issue and we need to treat people as individuals. People need individualized medical plans. And I think that might not be happening because there's a perceived lack of time and decreased staff and reimbursement. Because if you don't reimburse physicians for their time, they will find a way to check the boxes and move on so they can get paid. So those are my thoughts, but I'd love to hear your thoughts, of course.
Yeah, no, I love it. I love it. It's so sad that they've made the FDA black box warning for this back since 2008, right? This is over, a couple of years, decades almost. And it's like, what have we done? Like, what have we done if it's increasing? And of course, like you say, population numbers, people are aging longer. Those are all factors. But it's sad when there are even disparities in demographics with this. Like there was a study even showing that there's a 1.7 higher use of antipsychotics in Black dementia patients when compared to white counterparts. And that was something I didn't know until a recent study. So it's crazy that now this use of chemical ataxia or whatever is in a way causing some marginalized differences in outcomes, which again, I did not know until I started looking into it. Yeah. So we're seeing hits with disparities there, but we generally know dementia is going to be a higher prevalence in Latino and Black Americans. Does that mean that they were a harm to themselves and you do have a legal, justification to use an antipsychotic? Maybe, maybe not, but there's still a disparity that needs to be addressed. So I have thoughts about that. But in terms of what I see, you know, it's pretty common. There's almost always a Seroquel somewhere. Don't really see clozapine as much. But I am so tired of seeing benzodiazepines and opioids. Like so tired. And 70-year-old, 80-year-old women, like, what the hell are we doing? Like, can we do better? What are you seeing in the ER?
Yeah, I definitely see benzos and narcotics prescribed long-term for people who are aging, like daily prescriptions, not like I have a humeral fracture, I broke my arm and I need a narcotic for a few days. Like, I mean, obviously my stance is that if people have an acute issue, I think that narcotics can be a reasonable choice. I do think that people living with dementia need to have their pain addressed, because we know that people who have pain out of proportion and uncontrolled pain, it does cause delirium. So it does increase their risk of needing hospitalization and needing to be chemically sedated potentially if their pain is not addressed. So, but I think more education on other ways to treat pain, topical meds, because the problem is too, that's another issue. There aren't a lot of good pain medicines. You got Tylenol, which is pretty much safe in everybody. And you have NSAIDs, which can be a huge problem in people who are aging. And then you have like tramadol, which is a drug I don't like, and the narcotics, you know, and then you've got topical stuff. It's just that there isn't a lot to go to. But the chronic use of narcotics is a problem, and it's something that I don't think my patients really understand. When I tell them, hey, look, how long have you been on this narcotic? Do you realize that if you stop taking it, you're going to withdraw? Same thing with benzos. Like, do you realize that if you don't take this, it's going to make you sick? And they're like, oh, no, didn't know that. You know, and I'm like, did you know that this can make you constipated, this narcotic, you know, and that it works in your brain? And, you know, no, I didn't know that. So it's a problem that people are not educated on the potential side effects of these medications, both in the short term and the long term. So, lots of problems with those drugs. And
lots of problems. They're expensive. And frankly, we don't even have evidence past 3 months. Like, we really don't have strong evidence for chronic opioid use. Maybe, of course, for cancer-related pains and other special situations. But truthfully, past 3 months, there's like no evidence that says you need to be on it. It's more, hey, I need it now, you know, and you end up stuck. And I'm not saying everyone is abusing or an addict, but it touches the pain. Don't get me wrong. I've had a experienced Percocet myself lately after getting my wisdom teeth removed. So I get that. But it's not the catch-all. And what I think Western medicine may be missing is the biopsychosocial feedback of pain. Pain isn't just your body. There's a social element to it. There's a psychological element to it. And they all feed into each other. And so it requires us to think a bit more holistically, and maybe using mindfulness therapies. Maybe, of course, exercise can be an option. Maybe therapy, of course, I've already mentioned that. But having social support, having community, having people out of isolation and get you up and going and feeling like an active member can honestly help your pain go away. So I don't know. Yeah. What do you think?
Yeah, no, I think you're right. I think that we've thrown a Band-Aid on pain because, you know, back before I was practicing medicine, we were told that the physicians in the medical community were told that these drugs were safe, you know, and they do help people with pain in the short term. So I think we were just throwing on them like, you know, Band-Aids. But this is like this goes back to the problems that we see in healthcare, right? It's like we want a quick fix, and we're going to design things to react to problems instead of getting to the underlying issue. Like, why is this person experiencing like crazy pain, you know, that we see is real, like they're suffering, right? And then someone else who has the exact same condition doesn't feel that way, you know, like wouldn't know. Like, what is the difference between these two folks? And, you know, like you said, are there other things that we can do holistically to help this person so they don't have to use narcotics? I think that people living with dementia, unfortunately, like the interventions and things that we may be able to do for them right now, I don't think are there. Like, I think we need to get people earlier on this, like fixing pain and looking at how they experiencing pain kind of journey before before they develop dementia. But yeah, I think there's more work to be done, and therapy, 100%, right? So like,
Yeah.
we throw benzos at people because of anxiety. And it's not, it doesn't, it's short-term treats panic. It doesn't treat generalized anxiety, right? So what we're showing, we're throwing these medications at people and it makes them feel better. But the antidepressants don't make them feel better because it takes a long time. And therapy is probably what people would benefit from the most. I tell my patients all the time, you got to see a therapist. These drugs are only half their tool, right? They're not.
Absolutely.
So yeah, but I think when you think about doing therapy, obviously for someone living with dementia, it's going to just depend on the person, on their abilities at that point. So, but yeah.
Yeah. Yeah. And just to circle back, I mean, sometimes we forget that chronic pain can actually lead to dementia. It's a risk factor for being dementia, like having low sleep hygiene. Those are another risk factors for dementia. Just having a history of depression can another be a risk factor.
Yeah.
So that's why I think, again, we got to treat the whole mind, body, spirit needs to be put into play. But following up with your point on the differences in like one patient versus another, that's the perfect segue for pharmacogenomics. A lot of these patients, like they go through these liver enzymes, and depending how a person responds can be based on their genes, and that can dictate, should you take 100 milligrams or 10 milligrams of this oxycodone? It makes a huge difference, but everyone is personal, and everyone, I think, is shifting to more personalized care.
Yeah. And I think that's what we're able to do now, professionals coming online and providing education like this. I think slowly we'll turn the tide and change things. But pharmacogenetics is awesome. It's fantastic. I mean, I'm not a primary care doctor, I'm an ER doctor, but I think pharmacogenetics can save you from coming into the emergency department. We could spout off lots of reasons why. I mean, one of them you just mentioned, like if you get a lower dose of a narcotic, it's more appropriate for you. You're less likely to have decreased breathing, decreased blood pressure, increased falling, especially for someone living with dementia. So I tell people that with dementia, it's not a bad idea to do this, do pharmacogenetic testing as soon as we realize that some cognitive issue is happening. When we're trying to get a diagnosis, like why not do this when we're doing that? And then if your person has dementia, and they're not towards end of life, they're in the middle stages, or maybe in the earlier part of the late stages, it could benefit them to have pharmacogenetic testing, especially if people are trying to give them medications to sedate them and to control behaviors. So yeah, I think Pamela wrote a comment about pain patches being removed because a loved one doesn't know what it's for. That is an issue, Pamela. That does happen, and that could cause withdrawal if that's a fentanyl patch. I don't know what patch that is, but that could cause a problem. I mean, also people who are living with dementia who are at home and they're managing their own medications, it's very common they take too much insulin, they take too many of their medicines, they can take an extra dose of pain medicine, and they could put on an extra patch and not see it. There's all kinds of problems. So but yeah.
Oh, I love it. No, we love it. The comments are going wild. Thank you, Pamela, for that comment. I mean, it's so real. But yeah, especially if we know what type of pain patch that is, that could be a big issue. So thanks. But yeah, PGX, pharmacogenomics, personalized medicine is becoming the wave, is becoming the standard of care, slowly but surely. We do know that Medicare and Medicaid in some states actually does pay for that. So that could be a question that you could pose with your provider if you were curious about that. You can always reach out to either of us if you have concerns or questions of what that means or what that may entail. But it's fairly straightforward. Cheek swab. You get results in about 10 to 14 days, telling you based on your medicines which are best for you or which may be inappropriate or which may be just completely ineffective. And so that's the beauty of some of this. It's not going to tell you everything, but it gives you a good rundown of some of the more commonly seen medications. Pamela followed up and said, luckily, it was just a lidocaine patch.
Okay.
So okay with that. But no, like when we're talking about these opioids, I mean, I was just doing a medication review today, right? And talking with the caregiver provider, this poor 85-year-old having, unfortunately, this benign tumor causing all this pressure in his brain, and it's
Oh,
leading to cognitive impairment. So
mhm.
here I am wondering, he's a falls risk. He's on like 3 different blood pressure lowering drugs.
Okay.
His blood pressure was like 80/50 a month ago.
Okay.
And here we are sedating him and making this guy potentially fall out. So
Yeah.
why is he on tramadol? And I asked that, and the caregiver's like, you know what? I don't know why. He doesn't have any pain. So he
Oh,
doesn't have any pain, but why is he on
it's,
this tramadol?
yeah, and this is what I teach inside of my course, and I talk about it online. It's like and you are a champion of this. It's like every medication must have a purpose, and that purpose must go in line with the person's goals of care. So
Correct.
it's, and if you're on more than five or more medicines, you need to get with someone like Dr. Jalon and go over, do a medication review. Your doctor should cover it on an annual visit. I mean, it's kind of crazy to me that we only cover it once a year, but 100% medications need to have a reason. And so I tell people, like, you can't just, this sounds crazy, but it's not. You can't just trust the healthcare system to do what's best for you. Like, you need to question us and be like, why are you writing me this prescription? Make sure that you know why we're writing it. Like, I hate tramadol. That's like one of my. I hardly ever prescribe it. It's only if someone's taken it before that I'll give it to them. I hardly ever would write that as a new prescription for someone. There's just so many weird things can happen with it. And it's one of the ones that people can be like a very over metabolizer or under metabolizer.
Correct.
Yeah. Okay. Yeah.
Correct.
Because I've seen people like taking a tiny dose of it and being gorked, and then people who have taken the same person being fine. It's just such a weird drug. But.
Yeah, I've absolutely filled 360 tramadols to like 8 times a day. Like, I've definitely done that, and it's like still not cutting their pain. But like you said, no, it's subjective. It's a genetically cleared drug, so depending on that variation, it does get cleared by cytochrome CYP2D6 as well as CYP3A4. 2D6 is the main pathway, and when it's cleared, that active drug is actually more potent, or it works better than tramadol because it's a prodrug. That all being said, if your genes say, nah, I don't like that, it's not going to work. Or I love it, I'm going to clear it all now, it won't touch your pain. So that's that precision medicine lens that we're touching on, and why pharmacogenomics, I believe, will be the standard of care, especially if insurers are covering it now. Outside of just Medicare, but Blue Cross Blue Shield, United Healthcare are some of the more proponents of covering genetic testing with the right indications. So, but all of this still comes back to how we can do way better when it comes to how we manage people holistically, especially, again, in the dementia caregiving space. So, I'd love to know, like, when you're in the ER, like, what are some patterns you may be seeing or witnessing in some of our seniors, or just in general?
Yeah, I think there's a few things that I notice quite often. Like you just mentioned, the man being on all the blood pressure medicine. So, people living with dementia start to eat and drink less at a certain point, or if they get sick with some sort of virus or pneumonia or anything, like just any illness, they eat and drink less, they get dehydrated, or they're losing weight. And then we keep giving them their blood pressure medicines while they're sick, or while they're not eating or drinking as much, or they're losing weight. And people have kidney injury because of their low blood pressure. Now they fall and hit their head and are injured. Then they're not perfusing their brain because their blood pressure is low. They're not getting good blood flow to their brain. So that can cause worsening memory issues in the short term. So blood pressure is a common thing that I see. Probably one of the most common thing in all aging folks is like being over medicated. Either every day they're over medicated because no one's taken a look at this big picture for a while, or they're acutely ill and now they're being over medicated situationally. And so what I teach dementia family members is like, it's all going back to the same thing, right? It's like, every medicine they take, what they take, and what it's for. And then you have a plan for those medicines going forward based on your person's goals of care. So, and then that ties into blood thinners. So blood thinners are a huge issue.
Yeah.
And, they increase the risk of bleeding everywhere. They're thinning your blood. And there's different ones. The antiplatelets are not blood thinners, but they do increase the risk of bleeding still. So issues with those drugs, and then issues with like traditional anticoagulants. And so those situations are probably the most common things that I see. And then another big thing with everyone, not just people who are aging, not just people who are living with dementia, the NSAIDs causing GI bleeds. So that's like, people just don't know. Like, people take naproxen and ibuprofen together on the same day, like all day long, like for days. They're like, oh, my back hurts, let me take some Aleve, let me take some ibuprofen, and then it's just a downstream effect. So those are the anticoagulants, antiplatelets, then like any combination of antihypertensives, including the beta blockers, and then NSAIDs, and then obviously like narcotics, benzos, and antipsychotics. And then throw Benadryl in there. I don't see as many people taking Benadryl. Like, no one's prescribing. Like, I don't see people prescribing Benadryl, but I see people taking Benadryl and then not telling us that they're taking it.
Right.
So.
Right. Absolutely. Man, I love that. You really nailed some of the classes that I actually highlight in our 4th module of the Deprescribing Accelerator. So we literally list out the top 10 medication classes that send seniors to the ER, which is Dr. Lamb's world. So we literally list NSAIDs as number 1. We talk about blood pressure meds as like maybe number 3 or 4. Cancer drugs is like maybe number 8. We talk about blood thinners, antiplatelets, those warfarin type drugs, clopidogrel. They all have a pretty significant risk if a person falls. And some of them even have genetic implications, like our blood thinners. Plavix is a big one. Big one. So 2C19 is a huge one. So people, particularly those who may have Asian ancestry, are more likely to be unable to process that drug. When that happens, you're going to be at risk of potentially having strokes or a recurrent stroke if it's supposed to keep your blood thin.
It just doesn't work.
Exactly. It doesn't work. It won't work because your genes are saying it won't work. And a lot of our dementia patients may be on some of these drugs, right? Let's be honest. When people have dementia, they have all types of chronic conditions going on. So it's important to keep all of this in play, not just for the patient's well-being, but for the caregiver and the provider. So I'm so glad you mentioned that, because I think that's a perfect talking point about falls and dementia. And like, we know that there's going to be some mobility or maybe some walking concerns or gait issues with people that may suffer from that.
Yeah.
Have you experienced that in your line of work?
Oh my gosh, are you kidding? Yes, every single day we see someone who falls that's living with dementia. And that, to derail your point just for like 1 second, if your person lives in a facility and they have dementia, they're living with dementia and they live in a facility, you 100% need to know what the policy is if your person falls, because we harm people when they come into the ER and they stay in the hospital. We don't mean to, we're well-intentioned, but when someone rolls in after they fall, and they can't tell us what happened because they're living with dementia, then we start to look for reasons why they may have fallen, other than just they bumped onto something and lost their balance and fell. We start looking for medical reasons why they fell. And then they get blood work, they get a urine, they get their head scans, they get all these tests done. And I'm not saying it's not always necessary. Sometimes it is necessary. But sometimes you can't tell just by looking at the person and examining them, what could have caused them to fall. So you need to know what the plan is if your person falls, especially if they don't seem confused, they're not bleeding, they're moving everything like they normally do, they don't seem like they're in pain. Like, there may not be benefit in actually coming to the ER. And I think advocating for that side of things is something that I have to say. I know that's not what but it's part of it. Falls are so common, and falls in aging in general, but even more so in dementia, because you lose the safety awareness, and then depending on what area of your brain is affected, what type of disease that's causing dementia the person is suffering with, they may be more at risk. So like Lewy body, Parkinson's, dementia, they've got autonomic blood pressure issues, more at risk. So there's all different types of reasons why, but super, super common. And I think that if you're keeping your person at home, you can actually get training on, well, first off, you can ask for a fall assessment and do things in your house to make it safer, but you can actually take online training now about how to decrease the risk of falling. So occupational therapists are coming online too. So I know somebody, her name is Amelia Borland. She's inside of my Facebook community. There's all kinds of ways to educate yourself to help with falls, but medications are a cause of falls. And so, that's why you need to know what your person is taking. And I would say that the planning piece of medications has to be looked at, because we can't just continue medications to continue them. We need a plan for what to do with these blood pressure medicines if someone gets sick and they're not eating and drinking, especially that. So those are my 2 cents. There's like people writing things, Delon.
Yeah, man, they are blowing up. Christy Jones was commenting on tramadol not being the best. She was saying what medication a person with dementia that has taken tramadol for a long time in the past can take for knee pain. So she was more so asking what can she consider. She's just realizing that tramadol isn't doing anything for her. And that's sometimes the case, right?
Yeah. Yeah, Christy, I would say for that, one, you need to know why your person has knee pain to really know how best to treat it, because there may be things that can be done, injections. Then I don't know if that's even possible for you to get your person somewhere to have that type of treatment done. But I will say that a topical like BioFreeze, I have found a lot of patients tell me they love BioFreeze. It's like a gel that you rub on and then you put ice on top of it. Make sure you wash your hands or make your fingers go numb. But that's one thing that you can do. That's that's safe and not something that you would have to ingest. But that's tough, because it depends on your person whether or not they could take Tylenol and NSAIDs, and then there's a risk there. So, but pain is so tough, back pain, knee pain, joint pain. It is a like kind of impossible situation to get someone completely out of pain. And then giving the meds, and I think you would agree with me, Delon, is that like it is an individualized decision, and it's based on the risk versus the potential benefit of each drug that we consider.
For sure. For sure. I mean, you nailed it. I nailed it. I mean, we, like you mentioned, we're treating the whole patient, not just your symptom. That's what we miss in clinical practice. So I love liniments. I love things like Bengay, Icy Hot. I love those TENS devices, a little electric shock machine you can put if you have backaches, lower back pain. I don't know if you noticed, but the FDA just released this really cool virtual reality headset that people who suffer from lower chronic back pain can get this VR headset sent straight to their home, FDA approved, and essentially you can go through 8 weeks of what's considered cognitive behavioral therapy. And teaching you like ways to disassociate from your pain, how to kind of woo-saw around it, how to do other things to lower it. And they've statistically proven that it's improved their pain. So it's crazy, but this is where medicine's going,
Yeah. I mean, that's definitely, I think VR would be really interesting. I haven't seen any data on it in people living with dementia, but I'm sure some people would benefit from from it. So yeah.
For sure. Another thank you, Christy, for your comment. Pamela tuned in. She was saying and reiterating, hey, we have to know our personal goals and what the treatment plan is. So we are all for that. And Pamela also agrees. She likes BioFreeze as much as you do. So yeah, I get that. Christy followed up mentioning that knee pain was actually its own bone on bone. So it's a little tough for her. She can't do much with the cold. I'm sure she could probably tell when it's about to rain. I have a friend who had that issue. Unfortunately, it's hard for her to manage. So I'm curious if she's considered physical therapy or braces. I'm not sure, but I don't know how to quite handle that. But I'm all about other approaches. And maybe even chiropractor or acupuncture could be an option if it was exhausted. And acupuncture can be covered for a couple sessions, not all, on Medicare. So that could be a consideration.
Yeah, I would just take a holistic look at her, Christy, and ask if there's anything else. But I mean, you may not come up with an answer, honestly, because it's,
Mm-hmm.
if it's bone on bone and they're not offering surgery, then because that's probably what would need to happen is a joint replacement, and she may not be a candidate for surgery. So it's
Mm-hmm.
unfortunate, but that sometimes it does happen that we don't have a solution, and we just have to manage as best we can with other modalities. But
I
anyway,
love it. And so when you mentioned falls risk, it had me segue
yeah.
to our other module in our Deprescribing Accelerator, where we talk about deprescribing for dementia. And we specifically talk about falls risk and how there is an algorithm clinicians can use called the
Mhm.
steady falls risk, which is
Mhm.
STEADI.
Mhm.
Sheesh, drawing a blank on what the acronym means, but essentially it's a quick tool you can use developed by the CDC. And one of my professors, Dr. Stephanie Ferrari, who is a pharmacist and has a passion for community pharmacy and deprescribing. So
Mhm.
clinicians, if you're unsure of a med list, they have an algorithm where you can plug in a person's profile and
Mhm.
assess what their risk could be of potentially falling.
Mhm.
So that's something I use to kind of assess what's a proponent or what's a potential candidate to be deprescribed.
Mhm.
Another thing I like to assess, particularly in dementia, and this is more clinical, is looking at the anticholinergic burden. So it's
Mhm.
basically a marker that we suspect in dementia. It's a chemical in the brain that we think is just very little, and because there's so little, it can lead to basically changes in how we think, our mood and affect, and leads to some of those dementia hallmark symptoms we know. But as
Mhm.
clinicians, it's important to look out because you'd be surprised. Things like furosemide have an anticholinergic burden, right? Some of the
Mhm.
benzodiazepines have some of that. A
Mhm.
lot of drugs have that property. And so when you have one here, one there, they all can add up, and that can increase your falls risk too. So that's a
Mhm.
big thing we teach and preach in our deprescribing accelerator so that we're comfortable and not worried about, where do I start with this? We give you the tools to do that. But
Mhm.
yeah, what do you see in terms of the world of delirium? I know you're in an ER, so things are fast paced, kind of uncomfortable, but I'm curious
Yeah.
how you guys handle that when you see it in rep.
Yeah, I think that we do have patients that come in already delirious. That does happen. I would say it's more common that people come in um, not delirious. And well, there's different types of delirium, right? So there's the agitated hyperdelirium, but there's also hypodelirium. And that is probably what I see more commonly is when people withdraw and they're slow, and so everybody's like there's something wrong with them. They're just not them. They're off. And
Mm-hmm.
that's more common, and that's going to typically come. I mean, there's so many causes. Medications are a cause, obviously, but infection is a big cause.
Mm-hmm.
Dehydration,
Oh yeah.
infection's huge. That's one of the most common causes of it. But medications, I just harp. That's why I'm always harping on the nurses about make sure you get their med list. And, I do
Mm-hmm.
want to say this. So when you come into the emergency department with someone living with dementia, I can't tell you how much it helps me to have an actual physical piece of paper med list. Like, because it does a few things. One, it actually makes you take ownership of the situation and document the medications and why you're taking them, why your person's taking them. And everyone should do this for themselves as well. So it does that. It kind of gives you that you're learning, right, while you do this and keep it updated. But that's the other thing is that so you do this, you're learning, but you're also then going to keep this list updated. And you are going to be the best person to make sure your medication list is actually updated. Because I'll tell you, people tell me all the time, just look in the chart. It's in the chart. It's there.
Yeah.
And it's just not like there's medications that don't get canceled.
No.
There's dosage changes that don't get changed.
Right.
The nurses in the ER are responsible for doing this, and they have lots of patients. They have a sick patient. You think they're going to go through your medication list with you? Like, no, they're
Right.
not. And
No.
it's not because they don't care. It's because they don't have time and they're prioritizing what they're doing, just like we all do in our entire everything we do in life. We have
Exactly.
priorities. So I tell people a physical list that also helps us be able to better make sure your med list is accurate in the computer. And I'll also say that thing will let me stay in your room longer.
That's nice. That's
Yeah,
a
right?
great tip.
Yeah.
That's a great tip.
You give
As you do
me, you can have a conversation with me about not just your med list, but if you have your organized like medical history on paper, then I don't have to go to my computer and look at it. And when
right.
I go to my computer, what happens? I sit down, I'm there. Dr. Lamb, can you come over here and look at this patient? They don't look very well. Hey, Dr. Lamb, there's someone on the phone for you. Hey, here's an
Mhm,
EKG. Like constant
mhm,
interruptions. That's all. That's
mhm.
part of why we're stressed out. And when we sit on the computer, we're really
Yeah,
working, you know? So a physical med list, I can't plug it enough.
yeah. I
But
love a doctor that asks for a med list. Sheesh. I mean, it's like this is why we get along so well,
But
Dr.
I mean,
Lamb.
come on. Half the reason the people are there is because of their medicines. I mean, we know this, right? Like
Yep.
what we do in healthcare is there's a problem. Oh, there's a medicine for that. Let me add
Right.
that to your what you're doing, you know? And it's not right, especially for people living with dementia. You can't do that. You cannot do that.
Mm-mm.
It's
No.
inappropriate.
It's
So,
very inappropriate. It's why we're seeing spikes in these issues, and well, why we're here to try to save the day.
mm.
So thank you for that. Pamela helped save me a little bit and got the acronym for the Steady Falls Risk Assessment I mentioned.
Oh, that's
Stopping
great.
stopping elderly accidents, death,
That's
and
an injury.
injuries.
I love
Thank you,
that.
Pam. And she also mentions as a tip that she carries a list with the power of attorney and healthcare directives. And I know that's a bit more in your line of work. You care to share more on that, Dr. Lamb?
Yeah. So, when we're talking about dementia, so in order to do a medical power of attorney or healthcare advance directives where you're writing down what you would want if you were unable to speak for yourself, you do have to have capacity in order to make those documents legal. And when I say capacity, I use that term for a reason because you're going to hear it. You need to know what it means. It basically means that you're actually able to make your own you're able to make your own decisions. You
Mm,
understand what you're reading, what you're signing, why you're signing it, the reasoning behind it.
right.
People in the middle stages of dementia start to lose that ability they start to lose capacity in the middle stages of dementia. So they're not going to be able to do either of these documents. They won't be able to do a medical power of attorney or fill out advance directives, which
Mm,
is why it's so time sensitive. So if someone's starting to have symptoms, we're really concerned that this is not just normal aging. This is affecting their ability to function. We're maybe having trouble with work. We're having trouble with getting lost, and like the pathway to diagnosis of diseases that cause dementia. That is when we need to put the medical power of attorney and any advanced directives in place. But I also harp that those are tools. They are not a plan.
mm,
So these directives are not going to tell me in the ER what we're going to do if your person comes in.
mhm, mhm.
They give me an idea of what someone might want, but oftentimes the way they're worded is, if I'm in a terminal illness or I'm in an end stage condition, then I don't want my life prolonged. Well, we don't know that in the ER, almost never. We don't
Mm,
know. And if someone has terminal cancer, then that's different, right? We might know, but it's very hard. And so I find that advanced directives are over relied upon because people think that that's a plan. They think that they'll tell them what to do, and they just don't. So that's why I advocate so much for creating a medical decision plan for everyone who's making decisions on behalf of someone living with dementia.
mm.
That's what I teach inside my program.
Brilliant. I mean, I don't think I knew that. So I learned something myself. So, guys, I mean, I thought it was enough, but here we go.
Mm,
I stand corrected. So I'm so glad you shared that because I mean, not only are we both learning, but now I could have a plan for my family, right? I could
yeah,
advocate for my loved ones a bit more if that day comes. So I
yeah.
love that. Appreciate that.
Read the directives. Read them. And no, and see what they say. See, did they tell you what to do if your person has a stroke? What about if they're septic? They don't
Hmm.
say that. They usually talk about when someone would want to stop care, would want it withdrawn. So they don't tell us when to not start critical care, life prolonging care. And
Mhm.
if people reach a point in their life when they're living with dementia that they wouldn't want their life prolonged anymore artificially with our medical care, then then those advanced directives they're not going to tell us not to do that. It's only their decision maker that can tell us that.
Mm.
So it's really, really important So thank you for letting me talk about it.
Man, please do share away. And it seems Miss Pamela completely agrees with you. She says you have to know your person's wishes. You're right. It's not enough to just have advanced directives and POA. So thank you,
Yeah.
Pam. It's true.
They're
So
tools, but not a plan.
good stuff. Good stuff. Good stuff. I love it. I'm curious what questions you may have for me or anything you're curious
I mean,
about.
I would like for you to talk more about the anticholinergic. Like, tell me some more meds that I need to look out for that may be causing delirium that I'm not realizing, like things that are a little bit less obvious than what we've talked about.
You know, there's a really cool tool, completely free. It's called basically it's called anticholinergic burden calculator.
Okay.
So I use this, and this is another tool I teach within my Deprescribing accelerator course. But it's free, it's readily accessible. It makes you make a profile, but it looks at all these different awesome like tools made to assess this risk from across the world. And they put it all in one place. And it just tells me and breaks it down based on basically anything that has a score of a 3 or more is considered highly anticholinergic. I think furosemide is like a 1 or a 2. I'm drawing a blank. Of course, we know benzos have that issue.
Yeah.
Even some like less sedating antihistamine blockers like ranitidine or Allegra, they have like a 1 on that scale, right?
So if you take multiple.
Oh yeah, yes. So what it does is it looks at all the med lists, you put it in, and it ranks them on a scale. And if anything totals to more than 3, that tells us you have a high anticholinergic burden, which again can lead to that confusion, dementia-like symptoms, etc., and maybe falls risk in some situations. So there are quite a few drugs. The main ones, of course, we know are good old antipsychotic medicine. So classes of even if it's a first generation antipsychotic like Haldol, olanzapine, or a newer one, which is olanzapine, Seroquel, they have some anticholinergic burden, of course, right? Some opioids have some. I did not know that until I plugged that in. But some of them, even though we know they're a risk, some just have it based on their chemical structure. You don't have an explanation why. I'm trying to think. Was there some stomach medicine?
I didn't know about Lasix.
I have to check that thing, and this like it reminds me every time. Oh yeah, I'm so surprised.
Yeah,
but yeah,
I didn't. That was the big thing that you just taught me because and the fact that you have to remember that they all add up because I mean a lot of people take diuretics, Lasix. A lot of people are on those meds because heart failure is so prevalent.
Super. And heart failure, blood pressure, you name it. Like there are so many. Trying to think of what else comes to mind. I want to try to see if I could like sneak and pull this up.
I know. I think I found the website, but I'm not going to create a profile while I'm talking to you. Is this what it is?
Oh yeah, urinary retention meds, like meds for incontinence, big one.
Yeah. Okay.
Huge one. So gosh,
like oxybutynin.
Absolutely.
Okay.
Absolutely. That one's like a 3, 2 or 3. And a lot of those drugs in that class fall in that category. Yeah. That's a huge one. And of course, we have urinary incontinence if you have dysfunction with certain physiological things. So.
But it's also that's a good point that you make because like someone could get put on that medication because they're trying to help, but you could actually cause more harm in doing so. And knowing that in dementia, it is part of the disease progression. So people become incontinent. It's a natural part of the disease. And so should we like medicate that person? Again, it should be an individual decision based on their risk, and how much that's affecting their quality of life.
Right.
So, again, it's like looking at the person as a big picture. Another reason why I support pharmacogenetics and what you do, but also palliative care. So I think I think palliative care is really the what can fill the gap between primary care and all the specialists when it comes to people who are living with dementia, who still want to have medical care and still want to have, still want their life to be prolonged.
Right.
They still want to receive that type. They're not ready to be on hospice, which is a focus more on comfort, and not the treatments that we do for people who are living on hospice should have the primary intention of comfort first.
So true. Right.
But the palliative care is more, I feel like it's really the gap. It's the bridge between, it helps you look at the whole person, and they do medication reviews.
Right.
So they
usually
force you
deprescribe. They usually deprescribe. They think about it. Yeah. They want to think about it, but they want to do what's best for the patient's well-being, which I love. So, that's my favorite word. But when you talked about like what classes, man, there's so many. There are old school antidepressant drugs. There are asthma medications like Spiriva. So yes, an inhaler can contribute to that. Some people I've seen use something called benztropine. I never liked it, but it's used sometimes when people who are on these antipsychotics are maybe having like excretions, or they're drooling or tearing or whatever. And so they would give them sometimes these benztropine eye drops or the pill form to keep them from doing that. But that also has an anticholinergic burden as well. So yeah, there's a ton of classes that fall into that category. And that's why I think if you want to learn more, you can consider taking our Deprescribing Accelerator course. But there's so many. And of course, we cannot forget some of those over-the-counter sleep meds. Cannot forget Benadryl. We cannot forget Benadryl, the doxylamines, the Unisoms. They also have an anticholinergic burden as well. Be careful of that.
And that doxylamine, I think that's in a lot of cough and cold medications.
Yep.
That's the like sleep medicine that gets tucked into those.
Yeah. Yep. It sure is. Mainly used for sleep, and people say all the time, use it for sleep here and there, but it's a big no-no in the world of dementia. So again, we're here. We're coming for you, dementia. We're coming for these preventable issues, right? We're trying to make a difference here. So
because I've heard cases too. I'm sure you've seen this. I know you've seen it because you've talked about it, where someone's just over medicated, and you strip back their medicines, and then they're okay. I mean, it's a big deal. I know that you've talked about how someone was on 20 meds, and you're like, what are we doing here? So you take them all back, and then they're a different person.
Yeah, man, it's a headache. It's a headache. But there's opportunity, and it's platforms like this that allow us to not just share our wisdom, but hopefully give you guys some immediate value. So, I'm curious. If the audience is still tuning in, we got 3 people watching live, one other on my Instagram. So if there are any like last minute questions, we're gonna hang out for a few more minutes. So we would love to hear your thoughts. This is Dr. Brittany Lamb. Go ahead and check out her website. Can you remind us what your website is to learn more about your course?
It's B as in boy or Brittany. And then it's Lamb. It's blambmd.com. So my first name B, and then Lamb like a sheep, MD.com.
Love it. So I went ahead, put your website in the chat. Go on ahead and check out your course. Of course, you can always check me out at GeriatRx.org. I'll put that in the chat as well. GeriatRx as in x-ray.org. Would be happy to answer any questions if there are any, or if you just want to reach out to us and get that medical care plan, contact Dr. Lamb. We're good people. We don't bite. We're doing this out of our hearts, and we just love advocating for our caregivers and our families managing their loved ones with dementia.
I second all of that. Go work with Dr. DeLon Canterbury, because he is the best.
Thank you.
I just love the work that you're doing, and I think that obviously you're still working with clients and patients, and families, but the Deprescribing Accelerator program for clinicians out there, or people who just want to advocate, and it's inside of a facility. I mean, there is a cost associated with it. So I don't think the individual family caregiver is really who you're targeting, but facilities like the hospital systems, I can't recommend what you're doing enough. it's so needed. And I wish it was part of the medical education and medical curriculum, and that's another angle. I just met someone. I think I need to connect you with somebody. It just popped into my mind.
Okay.
So yeah, we'll have to email about that. So
Let's do it. That's actually my goal, is to require this in every pharmacy school, medical school, nursing school in the next 5 years.
Yeah.
And since our course is already CE accredited for all of those professions, it should be a no-brainer to put this into a curriculum.
Yeah.
And a small secret, we did have an insurance company consider taking our course to train their staff. So hopefully they can implement deprescribing on a large scale. So I'm curious to see how that goes. So I'm excited for 2023. Any awesome things you're working on this year?
That's awesome. Well, I'm putting the first couple of rounds of people through my course and getting feedback from them. And I'm hoping to get in with some area agencies on aging to reach more people. So yeah, it's the start. I mean, you're farther ahead in your journey than I am, but I'm so happy to be doing this because, as you were saying, I mean, we are doing this partly out of the goodness of our heart, but this is also a way that I've been treating my burnout and frustrations, and it really has helped so much. And it's my exit path out of the ER when I decide that that's what I'm ready for. So, headphones modality.
Yeah, I mean, I so get it. That burnout killed my soul not too long ago. So that is why I left retail pharmacy from being a pharmacy manager for so long, and seeing the problems that you talk about and being a part of the problem, because I was just peddling those pills without really questioning after a while, because I didn't have the support and I didn't have really the incentive as much as I wanted to in my heart. I just didn't have the time or incentive, because you said it, we're prioritizing things and it's kind of low on the list. So polypharmacy is real, prescribing cascades are real, and our job is to stop them before we continue to add to the issue.
I love it. When you say prescribing cascades, you mean like when we just keep adding stuff? Can you tell me?
Yeah. I love it. It's a good question. Good question. So prescribing cascades are essentially a misdiagnosis of someone's symptoms as a brand new health condition. And you've alluded to it. Basically, you add one drug on, say you add an ibuprofen for pain. The ibuprofen leads to feet swelling or water retention. So now we're adding a diuretic to treat the side effect of that first drug. But now your diuretic has your electrolytes out of whack. So you're on potassium and sodium. So it ends up being a cascade of different drugs added on that lead to more harm, had we just stopped the first issue and found that it was more a side effect, not a condition.
Yeah.
So that's what prescribing cascades are. Yes, ma'am.
I'm glad to learn that term. Now I'm going to start using it.
You got to.
Polypharmacy, I've been using. Prescribing cascade, I love that.
Yes.
So much.
One of our attendees wanted to learn more about that virtual reality headset that's used for chronic pain. And so I'm going to put a link in the comments from Harvard Medical School about it. This was approved actually last year in 2022, but it's a virtual reality headset. It's called Ease VR Virtual Reality X. So Ease VRX. So I'm going to go ahead and put this in the chat so everyone can get some comments. So Amy asked that, so I want to go ahead and hook you up with that. But it was so cool when I, was doing the work for my program to see that they announced this. And again, they've had significant results. In fact, in just 15 minutes of cognitive behavioral therapy, they've seen about a 66% reported 30% reduction in pain compared to 40% in the control group. So definitely significant in seeing this. And there were lasting effects too. It didn't just go away once you stop treatment.
Yeah. Okay.
So that's
I'll have to look into that, because I'm start recommending it to my patients, I mean, anything we can do to treat any other adjunctive therapies, and we're always learning, and new research is always coming out, and lots of new developments. And I think the wellness and prevention side of things is just going to continue to get better.
Oh, yeah. It's not going away.
People are interested. I think more people are interested in learning and stopping what they see happening, from happening to them.
Yeah. And that's why the time is now to strike. And I'm calling you guys out. You guys have been following me. Stop waiting for your passions to just fall into your lap. Like, take charge of your destiny. Stop that burnout. Stop feeling frustrated. Stop feeling like you can't take a break. Do something different that aligns with your heart and aligns with why you got into this profession. That is the entire point of my Deprescribing Accelerator. It's not about me. It's about our seniors, and it's about aligning what we were meant to do in a way that gets us paid and gets us a lifestyle that we can enjoy ourselves, right? All this work and then just die in a couple years and you're unhappy. Yeah. It's not worth it. That's not worth it.
I totally agree. It's like I think we pigeonhole ourselves as professionals into thinking, oh, I'm just a pharmacist. Oh, I'm just a doctor. No, like, you learn so many skills that you can put into practice. You don't even realize it until you stop thinking that way. It's the way, it's our mindsets, like the way we're wired when we're trained in healthcare. You're giving. And then you're not actually thinking about, wait a minute, do I actually enjoy this? Is this making my quality of life better? How is this impacting me? And that frustration you have with the healthcare system, like, find that thing that you want to fix, because that thing is a problem for so many people. And I want more people to come online and do what we're doing, because this is how you can reach so many people and impact and change on your own terms, right? You can do it on your own terms. So
yeah, I mean, I have a job and I'm all over the country, all over the world, and I'm not trying to brag. It's just I'm grateful and blessed, man, and I want this for everyone. Like, it was a struggle in the beginning. I didn't know what I was doing, but we're going to give you that guidance with our program, but we're going to show you the ways to not make the same mistakes I did in the beginning, so you can get fast tracked. And honestly, Dr. Lamb, we're on the same boat. It doesn't matter what time you start your journey, you're on the same journey. So even though I may be a little different or ahead, there is no ahead. You're on the right path if you're showing up today doing what you're supposed to do. So I so just appreciate your time and tuning in, and hope you guys found so much value. Again, I'm Dr. DeLon Canterbury. I'm a geriatric pharmacist and founder of GeriatRx, as well as a Deprescribing Accelerator. Dr. Lamb?
So I'm Dr. Brittany Lamb. I'm an ER doctor, and I help families of people living with dementia think about making a medical decision plan for the future, so that they're not stressed out making crisis decisions in the ER and the hospital.
Oh, man, I love it. We're a worst nightmare for dementia. So hope you guys loved it. Tune in next week for our next red pill versus blue pill. You guys take care.
Bye.
Later.